I'll be talking about the retinal blood flow circuit. I do not have any financial disclosure. Why is it important to look at the blood flow circuit? Because as we know that it is a very high turnover in these neuronal tissue of the retina, which requires an efficient oxygen delivery and the removal of waste products. Why do we need to know? Because probably that in one day we will be treating these pathologies at much more microscopic level than what we are treating now. We are talking about these big retinal veins, and eventually we may be talking about these small capillaries, and we may be treating at that level. So for this talk, I would be following this image, which clearly shows that there are 4 plexuses. I'm not going into the details, how did we reach here. The one which is present in the NFL layer, which is primarily a radial peripapillary network, which is seen mostly around the disc. And then the rest of the retina has, at least in the macular region, we see the superficial capillary plexus, intermediate capillary plexus, and the deep capillary plexus, and the bottom 2 are above and below the INL layer. So today's question is that are these plexuses are in series or parallel? So just moving back a little bit, I actually went into the Wikipedia and got this image from there, where we wanted to understand that whether these retinal blood vessel plexus are in parallel, that is each of these layers are having their own retinal arteries, arterioles and the venules, or they are in series that the one arteriole just goes on and supplies all 3 type of the plexus. Let's start with the pig model, which is supposedly very close to humans, and some of the humans definitely. So if you really look at the RPC, which is the radial peripapillary capillaries, which is seen right here, where you can see that these vessels are present parallelly, but we do not see any major arteriole, which we are able to see on a superficial venous plexuses, where you can see these arterioles and they are branching out and making this a layer. What about the intermediate, where we do not see again any major arteriole or venule? However, we just see the bunch of retinal arteriole or venules, where you can see these arrangement here. But in the situation of deep vascular plexus, where you can see a definite big venule, and I'll be coming to the detail of this in some of the human models. So what did they say in the porcine model? They say that the bulk of the arterial flow irrigates the superficial vascular plexuses, which is a cross road which supplies the RPCs as well as the intermediate and the deep vascular plexus. But the most of the flow, it actually transits through the deep vascular plexus. So each of these lines have clinical implication, which I have summarized towards the end. So just to understand that the major flow is coming through the superficial vascular plexus and then going to the RPCs and the intermediate and the deep one. Therefore, just to make it a little bit simpler, here you can see that the major arteriole supplies the SVP, goes into the RPC as well as the intermediate, and it goes into the deep venous, and then from there it goes into the major venous plexuses. Let's look at the normal human cadaver. This study was published from Sydney, where they again showed almost similar findings than the porcine model, where again we are seeing these parallel radial peripapillary capillary plexuses, which are straight and long capillary segments. They are either in Y or H pattern. What about the rest of the plexuses? As we saw in the porcine model, the superficial ones has the major branches of the retinal artery and the veins. The intermediate ones have the segments of the retinal arteriole and venules. However, there is no direct communication in the intermediate one between the arteriole and the venous system, but in the deep capillary plexus, where we can see there are closed vascular loops. However, we are missing the segments what we saw in the intermediate. They did propose various patterns of these arrangement. However, I think I just pulled out the most important message, which again goes what we discussed before, that the precapillary arterioles always connect to the superficial capillary plexus. And there is a reduction in the intercapillary distance in the RPC level, because we want to have the maximum blood supply in the nerve fiber layer. That's why the capillary supply is much higher. And the capillary diameters are significantly reducing as we go deeper in the retina. What about OCTA? This is definitely, we are also expecting that with the help of OCTA, we will be able to see the retinal vascular plexuses, but there is a challenge of projection. But with the newer devices, we are now able to remove these projection artifacts, which are producing a very good images, as you can see here. But in real life, we don't see such good images. But yes, for the publication's sake, we all have some of these very good images. This is just an example where we are trying to show that this is a CNV complex with the shadow projection artifact removal. You are able to see the complex very well. So using this technology, Dr. Huang group from Portland, they tried looking at the vascular anatomy of the human retina with the projection artifact removal, OCTA, and they did show these beautiful pictures, but I just picked up something very important for this particular talk, that they suggested that there is probably a parallel system where you can see in the middle picture that each of them have their own retinal vessel as well as venules as well as arteriole. But let's move on to something more interesting and more clinically oriented where we are interested. And this is the paper from Dr. Fruin's group where they tried to use the OCTA by looking at the collaterals, which we saw one of the very interesting cases in Crossfire as well. Just to show you the picture from this paper, you can see that this is a superficial vascular plexus where we can see that this cross you have to look at. This cross is through the superficial capillary plexus, and this is the deep vascular plexus where you can see this collateral which is matching exactly with the deep capillary plexus. That means the collaterals in BRVO are present at the deep capillary plexus. This is another example. Again, this is the collateral which again matches with the deep capillary plexus. This is the image where we did the shadow compensation for this paper. This is something which they are proposing, that there is predominantly a series arrangement, particularly at the venous end. So what is the clinical implication of all this story is that there are large number of feeder vessels connecting to the superficial capillary plexus to the RPCs, which effectively tells you that the RPC is really very well supplied. That's why it does not get affected in a much earlier stage of any microvascular disease, but the deep capillary plexus does get affected, and we saw that there is a capillary diameter reduction as well as we are going deeper into the retina. So there are greater number of drainer vessels which are connecting to the RPC to the SCP, which again suggests that there could be an effect on the deep circulation in retinal vein occlusion. And one more very important thing which we learned is that, again, the deep venous plexuses are predominantly venous, which we saw in one of the cartoons, where they are showing that the deep capillary plexus is predominantly venous in nature. Then again, it suggests that in situations in a systemic conditions where there is an increase in the central venous pressure, again, this layer or the blood vessels in this layer are going to get affected mostly. However, in this whole story, we are still removing the superpower of vasoregulation, which somewhere definitely is playing role, but we are still yet to explore and learn about this more. Thank you so much for your attention.